The knee joint can be injected from many directions, but a safe and convenient way is medially between the condyle and the patella. The patient sits with knee slightly flexed. Push the patella medially with the thumb and identify the gap immediately below the medial edge of the patella. Mark entry point here, clean and firmly stretch the skin and rapidly insert needle perpendicularly. Angle up underneath the patella, aspirate and inject as a bolus. The joint line runs at an oblique angle and the entry point lies on the anterior aspect. Please note, we never inject in the presence of an open wound. Find the joint line by gliding the fibula on the tibia. Mark the entry point here, clean and firmly stretch the skin and rapidly insert the needle perpendicularly. Angle upwards and laterally to penetrate the joint space. Aspirate and inject as a bolus. Place the knee at 90 degrees with the foot rotated laterally. The tibial plateau is then brought forward and the ligament lies along the medial margin. Mark entry point here, clean and firmly stretch the skin and rapidly insert the needle perpendicularly. Angle down onto the rim of the tibial plateau. Aspirate and pepper into the ligament. The medial collateral ligament runs in a broad band from above the medial condyle, inserting low down on the tibia. It is usually affected along the joint line. Mark the entry point at the tender area, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Aspirate and pepper into the ligament, taking care not to enter the joint space. The medial collateral ligament runs in a broad band from above the medial condyle, inserting low down on the tibia. It is usually affected along the joint line. Mark the entry point at the tender area, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Aspirate and pepper into the ligament, taking care not to enter the joint space. The bursa lies immediately deep to the infrapatellar tendon. The tender area is usually at midpoint of the tendon, which is approximately 2 fingers wide. Mark the entry point at the edge of the tendon, clean and firmly stretch the skin, and rapidly insert the needle perpendicularly. Pass behind the tendon to approximately midpoint, taking care not to enter into it. Aspirate and inject as a bolus. The bursa lies on the medial side of the knee and is identified by resisting knee flexion strongly while palpating the 3 medial hamstring tendons until they disappear on the edge of the tibia to form the pes anserinus. Immediately proximal and deep to this is the tender area of the bursa. Mark entry point here, clean and firmly stretch the skin, and rapidly insert needle perpendicularly. Pass slowly down to gently touch bone. Withdraw slightly, aspirate, and inject as a bolus. The bursa lies immediately below the distal end of the band. Palpate for tenderness and mark the entry point at epicenter. Clean and firmly stretch skin and rapidly insert needle perpendicularly. Pass needle down to gently touch bone. Withdraw slightly, aspirate, and inject as a bolus. The expansion is usually strained on the medial side at the superior pole of the patella. Push patella medially and hold it in place. Palpation identifies the extent of the tender area. Mark entry point here. Clean and firmly stretch the skin and rapidly insert needle perpendicularly. Pepper along the edge of the patella, avoiding entering the knee joint. The tendon arises from the inferior pole and is about 2 fingers wide. It's usually affected at its origin, which is found by depressing the superior pole downwards to make the inferior pole prominent. Identify the edge of the bone, mark entry point here, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle upwards to touch the rim of the patella. Pepper around the rim in both directions. The Baker's cyst lies in the popliteal fossa at the back of the knee. Identify midpoint of the fossa, move 2 fingers medially and 2 fingers distally. Mark entry point here, clean and firmly stretch the skin, and rapidly insert a large bore needle with a large syringe perpendicularly. Angle up and laterally so the needle slides anterior to the popliteal vessels. Slowly aspirate and dispose of fluid into containers for culture and disposal. Identify a triangular sulcus at the top of the talus between the inferior border of the lateral malleolus and the tibia. Mark entry point here, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle slowly upwards and medially to go over the top of the talus into the joint space. Aspirate and inject as a bolus. Palpate the sacrum tali, which lies immediately below the medial malleolus. Just posteriorly and slightly above is a small gap which is identified by tilting the talus. Mark the entry point here, clean and firmly stretch the skin, and rapidly insert the needle perpendicularly into the joint space. Aspirate and inject half the solution here. Slightly remove needle and angle anteriorly to pass through the septum that divides the joint. Inject remaining fluid as a bolus. The ligament arises from the medial malleolus and fans distally. It is usually affected at its origin. Mark the entry point at the centre of the tender area, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle upwards to gently touch the malleolus. Aspirate and pepper around the origin. The ligament runs from the anteroinferior aspect of the lateral malleolus to the top of the talus. It is approximately the width of the little finger and runs parallel to the sole of the foot. Mark the entry point at the centre of the ligament, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle upwards to gently touch bone of the lateral malleolus. Aspirate and pepper half the solution along the malleolus, then turn needle subcutaneously down towards the talus, gently touching bone, and pepper the remaining fluid here. The patient lies prone with foot strongly dorsiflexed against the injector's thigh. Identify and mark the centre of the tender area. Clean and firmly stretch the skin on one side of the tendon and rapidly insert the needle perpendicularly. Without entering the tendon, angle needle proximally so that it slides under the skin to its full length. Aspirate and inject half the solution as a bolus while withdrawing the needle. Repeat the procedure on the other side. The bursa is found in the triangle immediately anterior to the tendon. The safest approach is from the lateral side, avoiding posterior tibial vessels which lie on the medial side. Mark the entry point, clean and firmly stretch skin, and rapidly insert needle perpendicularly just in front of the tendon. Aspirate and inject as a bolus. Identify the joint line by palpation and by gliding the two bones. Mark the entry point at this joint line, clean and firmly stretch the skin, and rapidly insert needle perpendicularly into joint space. Aspirate and inject as a bolus. Find the joint line by extending and flexing the toe. Apply distraction and mark the entry point. Clean and firmly stretch skin and rapidly insert the needle perpendicularly into the joint space. If it does not enter straight away, flex the toe a little more and move the needle about until it is within the space. Aspirate and inject as a bolus. Ask the patient to evert the foot and palpate the small gap between the brevis and longus tendons. Mark the entry point here, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Angle subcutaneously so that the needle tip lies between the two tendons. Aspirate and inject as a bolus within the sheath. Palpate the tender area invariably found on the medial side of the calcaneum. Do not inject through the heel pad, but move distally to the edge of the pad where the soft area of sole begins. Mark entry point here, clean and firmly stretch skin, and rapidly insert needle perpendicularly. Slowly angle needle proximately at about 45 degrees until the point gently touches bone. Pepper along the enthesis. The patient is inside lying with the neck in flexion and side flexion away from the painful side. Identify the spinous processes and the tender facet joint. Mark the entry point, one finger distal to this joint. Clean and firmly stretch the skin and rapidly insert needle perpendicularly. Angle slowly proximally at about 30 degrees. Once needle tip gently touches bone of the facet, aspirate and inject in or around the joint as a bolus. Keep the needle parallel to the spinous processes at all times and do not angle medially. Feel the spinous processes. Approximately 2 fingers lateral lies the lumbar facet joint. Mark entry point, clean and firmly stretch skin, and rapidly insert a 3 to 4 inch spinal needle perpendicularly. Pass needle down to gently touch bone. Aspirate and inject in or around the facet joint as a bolus.